talking a little bit about bradycardia. Why is my patient bradycardic, right? Is it normal for them? If it is and my patient's hemodynamically stable, then leave them alone. They're fine. Stable bradycardias, we do not bother them. It's when bradycardias are unstable or the hemodynamic instability is found, or my patient is very symptomatic because of their heart rate. That is when we intervene and we treat the bradycardia if we suspect that the bradycardia is the cause of my patient's problems. That's it. Just because you get called to a call and the patient, someone has a heart rate of 30, but they're sitting there chilling, looking at you, complaining of whatever, they stubbed their toe or whatever their complaint might be. If it has nothing to do with their bradycardia, then just leave them alone, right? They need to go see a doctor. They need to go probably get an internal pacemaker placed, but they can do an elective surgery for that. They don't need emergency help for that. They're not going to do anything in the ER for that, right? In the ER, in the emergency room, they're going to be treating that patient with bradycardia if that patient has hemodynamic instability or they have symptoms that are brought on because of the bradycardia. Okay, that's the only time I need to intervene. Does my patient have a pacemaker? How do we know that our patient has a pacemaker? Can I see it? Whenever I do an inspection or I'm doing a secondary assessment on my patient, we always want to assess the chest, right? We always assess the chest for three things. We inspect, we auscultate, and we palpate, right? Not only am I palpating for obvious decap BTLS, but I'm also palpating to feel if my patient has a pacemaker. If you note a pacemaker and you look at your EKG and you do not see pacer spikes, what's going on? Is the pacemaker broken? Most of the time, your pacemaker is not firing because it doesn't have to. Not all pacemakers fire at all times. We call this on demand. On demand pacers fire when they need to. I actually had a really interesting call. I had a patient at the VA for military veterans, and the guy, when I walked in, the nurse told me, hey, listen, his blood pressure is extremely low. The last blood pressure we got was 60. I was like, holy shit, 60 systolic. And I'm looking at the guy and he looks terrible. He looks pale. He looks super weak. And I get him on our monitor. I get him on our stretcher. We start bringing him out to the truck and I'm looking at his rate, and his current rate when I'm looking at it was 72, right? His rate was 72. I print it out and I'm looking at it, and 72 with no P waves, narrow complex, okay? 72, no P waves, narrow complex. We're looking at accelerated junctional, okay? Accelerated junctional. So I'm looking at this accelerated junctional. I'm looking at the guy, he looks like shit. Then all of a sudden, his heart rate starts to drop. And then all of a sudden, I start seeing firing from his pacemaker on my EKG, and it's firing on his P waves. So if he's got pacer spikes on his P waves, what kind of pacemaker does he have? You see pacer spikes firing where the P wave should be. He has an atrial pacemaker, and it was on demand. So his pacemaker would fire only when he needed it to. The guy must have started to feel like crap and felt like he was probably going to pass out, went to the hospital. They saw him and his heart rate is fluctuating, and his pacemaker would kick on, fire back up to get his heart pumping to however fast it needed to, and then it would shut off. And then his heart rate would start to come back down and it would go and do it all over again. Interesting call for sure. But that is what an on-demand pacer is. Just because people, and just so you know, not all patients that have a pacemaker have ventricular pacers. Some people have atrial pacers, some people have ventricular pacers. We talked about this. Patient looks weak. Alter mental. Treatment includes fluids, okay? We need to treat this patient with fluids. They get on your stretcher. We have bradycardia. We have a decrease in cardiac output. We need to increase preload. How do we increase preload? By fluids. How much does my patient weigh? We're going to give up to 20 mLs per kilogram. Don't just say, I'm going to give a 500 bolus to this patient right now. Usually they need a little bit more than that. Pharmacology wise, how am I going to treat this patient? I want to start with atropine, okay? I want to start with atropine, especially if I don't know exactly what's going on with the patient. Maybe I looked already, I did my secondary assessment. I don't see a fistula, right? I'm not suspecting hyperkalemia. I'm not suspecting anything else or a toxin overdose. I'm going to start with atropine, okay? I can give atropine up to 3 milligrams. Then I need to make the decision. Is my patient stable enough or doing okay enough for me to give a pressor? Then I can consider epinephrine, or I can consider dopamine. Both are infusions, right? Both 60 drop sets. I can consider that. If my patient looks like they are going to die on me, and I've had a couple of these where you get them on the stretcher, their heart rate's 30, they look terrible, and you're like, oh, it's all right, we're getting a line, we're giving fluids, we're doing all this and that, and the patient starts doing this like head bob thing, like they're crashing on you, and you're like, oh gosh, let's just throw them on the pads, start it up, right? We'll do our TCP, transcutaneous pace. Atropine, what does it do? I remember I talked about acetylcholine earlier. Talking about our parasympathetic nervous system, you perform this parasympathetic, or you get this parasympathetic result from doing a vagal maneuver. You bear down acetylcholine signals, which is a neurotransmitter, goes to my receptor sites on my heart that will lower my heart rate. Well, if I give atropine to somebody, it blocks that from happening. That's all it's doing, okay? If you look what it says down here, what does it do? It stops the action of acetylcholine at the postgangliotic parasympathetic neuroeffector site. It increases heart rate and sympathetic bradydysrhythmias. The whole goal behind it is to stop acetylcholine. You get acetylcholine that gets to your heart because of a parasympathetic response. So basically, atropine just stops that from happening. Remember, we give out to 3 milligrams. If it doesn't work, we can move on. Use something else. Dopamine, talked a little bit about it today. Over here, and what does it do? At the bottom, produces positive inotropic and chronotropic effects. Remember, inotropic means increased contractility. You must know that for cardiology. Inotropic, increased contractility. Chronotropic, increased rate. Dromotropic, with a D. Dromotropic, increased conduction velocity. Okay, conduction velocity, dromotropic, heart rate increase, chronotropic, and contractility, inotropic. You must know all three of those. Will also constrict systemic vasculature, increasing blood pressure and preload. Increases myocardial contractility and stroke volume. Good drug. Nice part about pressors like dopamine. Remember, these are drips that we use with a 60 drop set. We open them up starting at around 5 mics per kilogram per minute, and we titrate to effect. We're going to open it up, start dropping it. Once we determine our rate, we just sit around monitoring the patient, monitoring their blood pressure. Once we see a blood pressure we like, we just shut it down. That's it. If we're sitting there and nothing's happening, or the blood pressure remains bad, we just make the drip go faster. It's super easy to use. It gets like, I don't know why a lot of providers are afraid to use pressors. Most of them they're always titrating to effect. So if you're not getting the results you want, just make it go faster. It's not a big deal. Epi, a lot of different reasons to use Epi. As you can see, there's a lot of shit here, man. Epi's a workhorse drug. It has effects on beta 1, which is your heart, beta 2, your lungs. It has alpha properties that causes vasoconstriction, used for patients in cardiac arrest, used for anaphylaxis, used for asthma, used for a lot of different things. Definitely know this med.